Palliative medicine is a very special type of medical care because it involves also special patients, and caring for dying patients involves a lot of other human beings, including families and doctors. The Professor Carlos Centeno Cortes is a professor, doctor in the hospital in Navarra, and in his presentation he will prove that care is not about providing for the basic needs, but also about arises from that opportunity. Professor, the floor is yours.
Dzień dobry. But this is one of the three words that I know in Polish. Other is dziękuję, and the another one is woda sodowa. Anyway, I'm very honored to be here, and I have to say to you, to all of you, congratulations for this extraordinary meeting in this lovely country. I think that here that we can see is a joint of efforts, starting with the memory of this extraordinary person that it was John of Dukla. Your memory of the history, of the memory of the life of this saint, is the best to congregate the people in this Congress to discuss an important issue as is the humanization in the medicine and in the world. And also we are doing that in an interdisciplinary way. And this is a value for all of us. Okay. In this presentation, the aim is to reflect of some peculiarities associated with palliative medicine and to outline what palliative medicine could mean for medicine. But keep in mind that my reflections are the reflection of a physician. I'm not a philosopher. I'm not an ethicist. I am a doctor that tries to reflect everyday bedside patient. It is important to note that in the first place, palliative medicine is special because the patient is special. The characteristics of a terminal patient or a patient with advanced disease means that they have special, peculiar needs. In addition, many professionals are specialized in end-of-life care, and they follow principles of the philosophy of palliative care. We are going to talk about that. But these professionals as professionals, we are very aware that not everyone can work in terminal care. And this requires a specific approach and involves their full humanity, which requires one to take care of themselves as a risk. Also, it has been said that palliative care serves to offer care when one cannot offer a cure. In this presentation, we shall study how it is possible to heal even when there is no cure. We will enter into the keys of this healing, the spiritual care that is offered by palliative care workers as many other professionals close to the patient at the end of life. To understand what palliative medicine means for the medicine, we have to understand first the patient, the palliative care patient. In general, it's a characteristic of the terminal stage of an illness that patients present multiple, intense, and variable symptoms. And normally, this situation is associated with a strong emotional element that affects both the patient and those that are close to them. But it's necessary to have a much deeper understanding of this type of patient. Fragility is one of the most characteristic aspects of the terminally ill patient. Frail can be defined as that which can easily be broken into pieces. The patient lives in an unstable world in which the smallest things can upset their equilibrium and lead them to require assistance. Both physically and cognitive fragility exist. The terminal ill patient is not only frail, but also very vulnerable, which means that defenses are very low. In physical terms, the deterioration in vitality is reflected also in the general syndrome or the general deterioration of the condition. In the emotional and spiritual spheres, the terminal situation becomes evident in different ways. The rules of the emotion are new at the end of life. Each patient will reach their end through their own personal experience of their illness. Nevertheless, it is important to consider that the terminal situation not only produces difficulties for the patient, but also it offers opportunities for personal enrichment and for establish even closer personal relationships. Anyway, the emotional instability and turbulence, the affective ambivalence, the rapid mood change are also characteristic in the psychology of the advanced patient. However, fear and anguish are usually also main components of the patient reaction. There is also a process at the spiritual level. For all patients, and in function of the conservation or not of the higher functions, the proximity of death provokes existential or spiritual needs that may become that most delicate and difficult than any other conditions. Nobody wants to die if they are well, and the natural reaction to the bad news of the proximity of death is rebellion. I don't want to die. Thus, it is often the spiritual care and the simple act of being there to provide companionship that helps the patient to die peacefully. I only want that is right. I only want to die without suffering. Cicely Saunders, social worker, nurse, and doctor, was the founder of the modern palliative care movement. Saunders dedicated her life to promote a new model of caring for terminal ill patients. In the book, The Management of Terminal Malignant Disease, published in London at the end of the 70s, reflects on the experience of a team that she brought together in the initial years of her work at St. Christopher Hospice. St. Christopher's was the first modern hospice established close to London in 1967 and founded after years of negotiation and in response to Saunders' personal experience and prayers. Thanks to the work of Saunders and to that of the many other pioneers in the field, palliative care today is considered as a new area of the medicine. In summary, the professionals of this discipline follow the concept of holistic care as their main directive for terminal care. Centered on the individual, excellence in systematic control and pain control, attention to the multidimensional problems affected by the disease in the emotional, spiritual, and social areas, and all of these elements combined in an interdisciplinary team aiming to alleviate the problems of both the patient and also the family. At this point, we can listen to Harvey Chochinov, who proposed to consider the A, B, C, and D of the medicine. With Chochinov, we think that the essence of the medicine is not in cure. Medicine does not to be in the cure, rather than in the A of attitude, you are important to me, in the B of behavior, you treat you with dignity and respect, in the C of compassion, move me to relieve your suffering, and in the D of dialogue, I listen to what you have to say me in order to treat you better. Is the A, B, C, and D of the medicine, published by Chochinov in The Lancet. In my perception, it's in palliative care where these essential elements of medicine can be seen better. What particular qualities does the palliative care professional need? Can anyone work in palliative care? What affects them and what helps them to overcome these problems? In the opinion of this author, not everyone is suited to caring for a terminally ill patient, or at least to care for them effectively. Bruera, a world leader of experience and prestige, resumed the issue by saying that to work in palliative care is needed to be very supportive and very compassive. The expression very supportive refers to the fact of being attentive to offer help, to be there and support whoever should need it. Cicely Sanders, in her conference, What's With Me, reminds us the words of Jesus in the garden, requesting the presence of his mother, dear disciple, that they should remain with him by his side in vigil. In these words, Cicely Sanders found the inspiration to dedicate her life to palliative care, being there, close to those that suffer near death. It is also necessary to arrive to the compassion. According with Chochinov, healthcare providers arrive at compassion through various channels. For some, compassion may be part of the natural disposition. For others, compassion slowly emerges with life experience, clinical practice, at the realization that, like patient, each of us is vulnerable. Compassion all may develop over time, and it may also be cultivated by the exposure to the medical humanities. Everyone can develop compassion through personal experience. Sometimes I hear, since I suffered that illness, since that happened to me, I can understand what the patients are going through, or the death of this close friend, or the illness of my father has helped me better understand the needs of my patient. These are my colleagues and sometimes myself. Anyone that offers care to a terminal patient with humanity and professionalism is offering palliative care, at least a basic level of palliative care. But also palliative care means specialized care. Then education, training, and experience are all necessary. Who wish to dedicate themselves to such care on a daily basis must achieve an advanced level of training and experience. But when caring patients every day, we need to looking after oneself to be able to care for others. Leading a healthy life is a help when working in palliative care. Outdoor activities, physical exercise, social interaction, free time, good diet, regular sleep, meditation, relaxed techniques, all are important elements of personal protection. But also, we have to remember that to care the spiritual life, the personal spiritual life, will permit the support of an essential source of vitality. When professionals with experience are asked what helps them to face the stress of the intense situation that they must deal with in palliative care, they tell the importance of leading a rich and ordered lifestyles. We can face the problems in our work on a daily basis, but outside of this environment, this should be compensated for with a rich or fulfilling home life. It is difficult to work with terminal patients without having one's own life in order, one's ideas clear, a life full of sense and meaning. Then medicine doesn't end in alleviation or palliation. It must still go one step further. We believe that the art of healing is always at the heart of the medical care. And that is the function of healing, the role of the healer, as to offer hope to a terminal patient in some sense, even though this may be only for a short time as a way to facilitate to die in peace. But healing is possible also at the end of life, in terminal care. To palliative care professional, the paradox is evident each day. It is possible to heal, to cure the terminal ill patient, as explained by one of the pioneers, the Canadian Belfort Mount. I would like also to reflect more on this idea that is illuminating the palliative care professional. When we refer to healing, we are not referring to physical healing. That we call healing here is the qualitative change in life that leads one to adapt from the cessation of anguish or suffering to experience a sense of integrity, of full and profound internal peace. The concept of healing that has been used more recently in medicine is associated with concepts of personal fulfillment, integrity, and spirituality. Healing will be the personal experience of the transcendence of the suffering. This leads us to the last question of how to perform this art of healing. How can the palliative care professional help to heal a patient that is going to die? According with Sinclair, to cure others, to cure everyone else, it is necessary to use the professional personal qualities, including own values and beliefs, but also with other essential skills that can be acquired and practiced. The first one is the capacity to listen. This refers to listening attentively to details, a listen that captures the tone, the silence, the implicit message. It is an intuitive form of listening that seeks to understand the patient's true needs. With time, it becomes understood as an instrumental way of listening that is not the end in itself, but rather the means for something deeper that occurs in the interior of the patient, opening them to the transcendental and towards a transcendence. It is said that this intuitive listening requires the palliative care professional to become an instrument, to feel that he is not important, that they are the catalyst of a process, rejecting any desire of protagonism in terms of the care offered. When we listen in this way, delicately, we will permit expression of suffering, such, why me, I don't understand, I don't want to die, with relief to the patient. Second, we have to learn to look and to see. The look of the professional who wants to heal must be full of affection. It's a look that reaches beyond the patient, that searches for the essence of their identity, and that unconditionally accepts them and their problems. For example, we refer to the look of a professional that is independent of the level of consciousness of the patient or the capacity to express gratitude or a more positive attitude. We have to learn to look at what cannot be seen, to observe the characteristic imminence of spirituality, to capture the divine spark that resides in all patients. This look also reads the surroundings, the bedside table, the room, the religious image, or the photos that they have at the site. Third, we have to know how to care through words. Along with listening and watching, there is the capacity to participate in conversation, the capacity of talk. But what is most important about this is the ability to control the speech than to exercise this capacity, dominate the language. Those who trust strongly on their capacity to communicate tend to block the personal process of the patient, suffocate the therapeutic flow of conversation that the patient themselves might have initiated. And when words are necessary for the existential care of the patient, to heal them, it is fundamental to say little, and excuse me, not put your foot in it. We must bear in mind that communication through words is potentially damaging. Also, we have to care physically. In fourth place, the palliative care professional must cultivate the capacity of becoming physically close to the patient. Physical contact is also part of this important aspect of those who wish to heal, particularly empathetic contact, healing with affection, taking hold of the hand at the time of having a therapeutic conversation or during emotional moments. A care of the shoulders at the time of the bad news. This physical contact with the patient, when appropriated, indicates that there is enough intimacy to deal with more serious matter. The physical care of the patient, caring for their body, has an effect that goes out to the physical and that also affects their well-being. For this reason, we must be aware of the therapeutic capacity of physical actions able to contribute to the spiritual care of the patient. The way in which we approach the patient, the way in which we dress, the attitude of the nurse when enters in the room to change a drip or to leave a medication, a massage in the painful region during a wash, or any professional taking care of minor details of the room. All of these offer extraordinary help to the patient interior processes. And finally, the presence of the professional. The capacity of the professional to help heal in profound aspect can be summarized in the therapeutic presence of the palliative care professional. We refer to the presence of someone as that of the professional who approach with a true desire to help in this situation. The patient perceives that the presence is genuine, immediately perceives that it's not only a doctor that is there, but rather someone who has came to offer help, that want to assist me personally, offering their true self, even being the doctor as well. To talk of the therapeutic presence of the professional is to refer to a presence requested. Don't leave me, be there, stay with me. Present is not to go to do something. Present it is not pass by, not even is to visit the patient. Present is to be there, to be part of the process of the patient, with the patient as he follows his own process. Moreover, is the presence of a vulnerable person, not only a doctor, but rather someone that will be affected by what happened to the patient and that will also be touched. In this feeling of vulnerability, affected by the suffering of the patient, there is something of sharing humanity. Yes, that affects me. I don't care that it affects me. And affects me, but I am still there. I'm not looking to distance myself, to put up a barrier to shoot out this emotion. Also, I maintain my calm, that is also a tool. But it doesn't bother to me that I am affected, because the more that I am affected, the more that I can help the patient. The presence of the professional requires abandoning the role of the doctor or nurse that knows all, that has an answer for everything. We learn that at times there is no answer, that at times the only thing that is worthwhile is silence. And after an initial period of discomfort, it is possible to experiment how best to collaborate through your presence in the process of finding peace, of healing the patient. And this also contributes to the interior enrichment of the professional who grows, develops, and improves. In conclusion, that is the art of healing, which pertains to the true essence of the medicine. And we try to practice this in palliative medicine. Healing and euthanasia are not compatible. Moreover, when life finishes, there is a space for healing, understood as the experience of the patient in transcending their own suffering. The palliative care professional that wants to collaborate in the healing of the patient should approach this in their own way and develop core caring skills. And among these is the present as a human being, as a vulnerable individual, while at the same time being present as a professional. And in this way, palliative medicine could serve as a new paradigm for the 21st century medicine. Understanding medicine as the art of healing, a medicine where the doctor will not be a curer of diseases, but rather a healer of patients. Thank you very much. Dziękuję.
Bardzo dziękujemy, pan profesor Centeno Cortez.
Thank you very much, Professor Cortez. Thank you for this lecture about palliative care, palliative medicine. So thank you for coming to the Congress.